welcome to In a Heartbeat, coming to you from the studio of WMTV Channel 5 in Grosse Pointe Farms at the Grosse Pointe War Memorial. As a reminder, you can also find us on the AT&T U-verse on Channel 99 and the WOW cable television network. I'm Dr. David Balle, and I'm your host for In a Heartbeat. It would be logical to think that repair of bone fractures from falls and sports injuries might be all that occupies an orthopedic surgeon's day. You may be surprised to learn that today's orthopedic surgeon is involved in so much more than that. And I'm really excited to learn about the practice and specialty of orthopedic surgery with my special guest today, who has a wide scope and broad range practice that I'm sure you will want to pull up a chair and listen to as well. She is a board-certified orthopedic surgeon who did her residency training at the University of Michigan, and her name is Dr. Julie Henry. Dr. Henry Kelly, welcome to In a Heartbeat.
Thank you, David.
It's a pleasure to have you here. Dr. Henry, you have a practice that I think is somewhat unique and interesting and very broad range in its scope. Not only do you do your orthopedic surgery, but you also offer many alternative treatments as well. And I was wondering if you could start out by talking to us a little bit about your practice and your office.
Sure. David, my practice is a general orthopedic practice, and I see all ages of patients, from children and up into the elderly population. We see a variety of conditions such as arthritis, fractures, congenital deformities, sports injuries, and fibromyalgia, lower back pain. So it is a really broad scope. And I treat patients surgically and non-surgically. My office is equipped with a physical therapy pool, it's called aquatic therapy. We also have therapy on what we call land, because it's not in the pool.
Land and sea.
Land and aquatic. We also offer some other services to patients, such as nutritional counseling, weight loss programs, and some other just alternative therapies, such as Reiki and massage in the office. So,
and I think that's really great, because I think in medicine in general and related to patient expectations and demand, I think people are looking for more of a broad range of options to choose from in terms of what the physician and the patient may work together and thinking what is the best treatment for them. And what I'd like to start out maybe in talking a little bit more about is your aquatic therapy. Tell us more about what that is and the facility that you have for that.
Aquatic therapy is physical therapy that's done in a pool. And it's an excellent way for patients to have their therapy done. One of the benefits of aquatic therapy is we can actually remove about 90% of the person's body weight due to the buoyancy in the pool. So in patients who have severe knee pain, hip pain, lower back pain, it allows them to do exercises in water that they wouldn't be able to do on land. Okay, so our pool is 10,000 gallons. It's graded from 3 feet in depth to 5 feet in depth, and the grading from 3 feet to 5 feet allows us to treat patients at different water levels and to take different percentages of body weight off of the lower extremities. So in the deep end, in the 5 feet of water, it will take about 90% of the patient's body weight off of the lower extremities. In the shallow end, in the 3 feet, it's about 60 to 70% of their body weight. So we can vary the amount of body weight that's taken off of the affected body portion that we're trying to treat. We keep the pool at about 91 to 92 degrees.
Nice.
It's very popular. And it's a bromine pool, so chlorine is a little bit more irritating to the skin, and the bromine is actually less irritating to the skin.
I like that.
Yes, I thought you might.
A question just comes to mind talking about people with lower back issues. Like, say, for example, if a person had back pain or difficulty with movement or getting around due to a herniated disc or, say, for example, spinal stenosis or a narrowing of the spine, could something like that be of benefit to them?
It's excellent for lower back pain and fibromyalgia. And both the treatment for low back pain and for fibromyalgia really is exercise and conditioning the body and core strengthening. We hear a lot about core strengthening, yes. And it is very important. And we do some exercise in the pool that do focus on core strengthening. And again, those in patients who have chronic pain and have severe pain, they are many times unable to do those exercises even on the land. They're unable to get into the positions, laying down in the pool or on land to be able to actually successfully do the exercises.
Are these individual therapies or group therapies, or how does that work?
In the pool,
yes.
They're individual.
Oh, very nice.
Yep,
very
it's
nice.
one-on-one.
Very nice. And with something like that, are those patients able to be more mobile and to make progress?
We've had some very nice results, really nice results.
And it sounds like it's really a unique thing, and I personally like the idea that that is done under the umbrella of a physician's office who's a specialist in that field, who really knows what they're doing.
Right. It is very helpful because the therapist can walk over to my office and we can change a treatment plan right there on the spot. You know, in a freestanding physical therapy center without a physician, you don't have that luxury. So, the physician or the physical therapist has direct access to me.
And as part of the alternative approaches that you can offer, in addition to your surgical practice, nutrition has become such an important part of what you do, and I'd like to hear about that.
Our nutrition program is based on a 12-week weight loss challenge, and it's a program that's been set up through Herbalife, which is a nutritional supplement, and they have a structured 12-week program, and each week focuses on a different portion of nutrition. One week might be protein, week might focus on fiber or water consumption. So we go through every aspect of a good nutritional base, and to try to teach the patients how to eat well and to make good choices. And we've had patients who come into our weight loss program where they were consuming we had one patient who was consuming up to 7,000 calories at McDonald's
a week. Oh my goodness.
A week.
Wow.
And so right there, by just basically helping her to make better choices and to cut out the fast food, she lost quite a bit of weight fairly early on.
And I think that is important because, I think a person may say, well, you should just eat better, but I think sometimes people don't know what that means or how to do that. And I think having it taught in a class and having more of a close relationship with somebody who can help you and answer your questions personally has to make a tremendous difference.
Right. Well, if you remember back to school, I think I had nutrition and the food pyramid in elementary school, right? So it's definitely beneficial to have a little bit of a refresher course.
Absolutely. And so as part of that, you have discussions and lectures, and you have, in your facility, they can get some of the nutrition, or you have like a bar there or something like that.
We do. We have a personal weight loss coach, and she basically works one-on-one with people, and she also works in a group setting. And then we have basically it's a little kind of program we offer where they can come in and get a healthy meal, which consists of a nutritional shake and iced tea and aloe. And there are nutritional benefits to each one of those. So if somebody were interested, we could set them up with all of the information they need, and they can come in and receive this healthy meal and sit down and talk to the coaches and talk to other people who are also going through weight loss, and it becomes a little bit more of a social setting also for people, and a little bit more supportive too.
And many of your patients probably have an issue with probably weight control, and so this is a needed part of their therapy. And from what you've said, it sounds like it's very comprehensive to be able to take care of them from every aspect. If they need surgical repair, you can offer that, and they have the other support and alternative treatment that they could benefit from and use as well.
Right, there definitely are benefits to losing weight before you have a major orthopedic procedure. Infection rates are increased in people who are obese, and that is one of the most devastating problems that we face in orthopedic surgery is postoperative infections. Mm-hmm. So if you can minimize your risk of infection by decreasing your weight, especially in a knee replacement or a hip replacement, it will benefit you long term, and you'll have a better success with your surgery.
Dr. Henry Kelly, you also have an alternative sort of medical wellness center within your practice and your facility, which involves various things which include physical therapy and massage, and I'd like to hear about that.
Okay. Well, we do the physical therapy, which is pretty conventional physical therapy, strengthening, sports rehabilitation, and we also offer Reiki, which is an energy therapy.
I was going to ask you, what is Reiki?
Well, Reiki is an energy therapy, and it basically, it has a lot of different uses. It's used in helping people deal with pain, with chronic pain. It's also used in helping people deal with chronic illnesses such as cancer. We've used it for patients who have fibromyalgia or who have chronic pain. It helps them to, it's supposed to center the person's energy, and it helps them to relax and be more at ease. And it helps to get rid of a lot of anxiety and stress that's associated with having chronic pain.
And I think studies have really shown that that can be very helpful and beneficial.
It's really starting to catch on, I think. And we also offer massage therapy, which has a lot of the same benefits in just relieving stress, in relaxing people, and it does help them deal with their medical conditions much better.
Also within your practice and the scope of the things that you do, outside of maybe the OR surgical realm, there are different things that you can offer patients that involve perhaps an injection of some type, whether it be a medicine, something to encourage healing, or a cortisone type of injection. And what are those options?
Well, I do quite a few injections, actually. We do cortisone injections, which is the most conventional injection for pain or for inflammation. It is an anti-inflammatory medication that's injected into either a joint or sometimes into a painful portion of the muscle that we call a trigger point. So it can be used in a number of different ways for that. It's also used if you were to receive an epidural, which I don't do at my facility, but we do have a pain clinic that right next door that does epidurals.
That's great, very convenient.
Right? And I also use a medication called Orthovisc, which is a form of hyaluronic acid that's used primarily in the knee. Right now, that's the FDA approval is for the knee. I have used it in the hip off-label, and I've had very good success with it in the hip as well.
And hyaluronic acids are naturally found in our skin, bones, and cartilage and help to give it structure and support.
Correct.
And it can help to repair an injury or how does it, do we know how it works?
Well, we think we do. The hyaluronic acid is one of the building blocks of the joint. And in the joint, it has been shown to help decrease inflammation. And it also has been shown to basically nourish the joint itself. It's basically a vitamin for the joint, and it helps to, I don't know that it replaces cartilage, but it does help to make it healthier, the cartilage that is there.
I see,
yeah.
I see. And many people have heard the term arthroscopy. Can you tell us what is that and what its indications are? Arthroscopy
is basically going into a joint. So arthro means joint, and oscopy means scope. So it means putting a camera into a joint and looking around. And then we also have special arthroscopic tools that we can actually do surgery in the joint. So minimally invasive surgery is a wonderful trend that we've had in the past 10 years of doing surgeries with the smaller incisions, and it's considered less invasive for the patient. They have better recovery times.
And I think that is very attractive to patients and to physicians as well for the medical benefits and the lower risk factor.
Absolutely.
Faster recovery.
It is. Years ago, to repair a meniscus, the incision was 4 to 5 inches long, and with an arthroscopic procedure, the procedure can be done with 3 or 4 1-centimeter incisions, so it's significantly improved from our old methods. And quite a bit can be done. The arthroscopy can be done in almost any joint. I do arthroscopy of the shoulder, elbow, hip. I don't do hip. I'm sorry, knee and ankle. Yeah. So
it's a wide territory.
Yeah, it can be done in the hip, but I personally don't do hip arthroscopy. Yeah.
And so, tell us a little bit about maybe the surgical aspect of your practice. You see people who have fractures and sports injuries, and what can you do to help them? And what do you end up doing in your surgical practice?
Well, it just depends. I mean, my day is so varied.
It's not planned, is it?
Right? No. So it's fun because the patients that come in, they do actually get better and they get pain relief with orthopedic surgery. And it's fun to see a patient that comes in severe pain and they have surgery and they come back a month later and after surgery and they're doing well. They're happy.
Yeah.
So orthopedic is a very rewarding field because of that, because we really are actually able to help people decrease their pain.
And just a question that would come to my mind, are there many female orthopedic surgeons?
No, there are not. And I would say it's about 5% female nationally. I don't know the exact statistics, but when I graduated from residency, it was 3.5%, and it's a little bit higher now. Probably, it'll probably get to 10% soon, hopefully.
Do you mind if I ask you, when you were sort of a pioneer, maybe in a way, or maybe what was that like? Being maybe, I don't know if there were other female residents at the time, but
at Michigan, we actually do. There are female orthopedic surgeons on staff, and so I don't know that I was a pioneer there, and I had some very, very good role models at the University of Michigan that were women. I think where I went to medical school, there were not any orthopedic surgeons that were women there. So Michigan became a good fit for me because I did have excellent role models that were women.
That's great, and I think that's great because I think it should reflect more what the general population is and not be a minority. And I think it's great that you were probably courageous and just said, this is what I feel I want to do and I'm going to be great at it, and you didn't let a standard perhaps kind of hold you back. That's great. That's wonderful. In terms of falling and getting an injury, whether it be a fracture or a sports injury, are there any risk factors that you think come to mind?
Well, we look at falls in the elderly population very seriously because I think the elderly population is more at risk for falls, and they also are more likely to have osteoporosis, which it can make a fall more devastating to the elderly patient. One thing that puts them at risk is loss of balance, dizziness, and also sometimes just losing eyesight and not being able to see if the path in front of them is clear. So they have a tendency to trip on different things, tripping on throw rugs. They also might have lower extremity weakness, and again, dragging their feet can cause tripping, and so. And
sometimes people, as we get older, sometimes can drag their feet because of various other things going on, either in their brain or their musculoskeletal system, and it's something that's pretty common, isn't it?
Absolutely. Weakness is the most common and the most treatable, I think, in the elderly population, but there can be a number of neurologic disorders that can cause lower extremity weakness and tripping as well. But we focus on the weakness, and even in a neurologic disorder, gait training can be taught and strengthening can be helpful as well. So we focus on strengthening, and we've also really made a push to screen for osteoporosis as well, and to treat osteoporosis if there is a known fall or a known risk factor for osteoporosis. So, in addition to preventing falls, we also try to minimize the damage that is a result of a fall.
Mm-hmm. And with osteoporosis, a patient's bones are sort of softer, so they're more predisposed to falling. And is there anything about the setup of a patient's environment that they should maybe look out for that comes to mind in the patients that you see, that, in terms of, where things are in the house, stairs, that they should be aware of?
Definitely. There are a number of things you can do to help people prevent falls in the home. Number one is any throw rugs that have a lip on the edge, or an edge that, like a stairwell that has any kind of a step up. Even a small 1 centimeter step up can be hazardous. One of the most common things is people tend to stack things on the stairs, and they don't have a clear path on the stairs. So just clearing out the stairs, clearing out any cords, lamp cords, or anything that is in the room, cable cords, those cords should all be picked up, and hallways should be kept clear. And then I think one thing is if you do have a dizziness or any loss of balance, is use a cane. Use some support to help yourself so you don't fall. It really can be preventive.
I want to ask you a question about that. Do you think there's ever a reluctance on a patient to maybe get a cane? Maybe they think they should, but there's maybe a certain sense of pride or in saying, well, maybe I don't really need one. Do you run across that?
Absolutely, absolutely.
And what would you say to a person who may be listening, who may be thinking in that light?
I would say that it really can make a difference. It really can prevent your falls. And even though you're using a cane, you might, if you did have a fall, you might need a wheelchair or a walker, which would be much worse than using a cane. So if you fall and break a hip or break an ankle, it can be quite a long recovery, and you lose quite a bit of your freedom. And some patients, especially in the elderly, have to spend some time in nursing homes and outside of their homes if they do have a devastating fall. So,
and you see children in addition to adults, and my awareness is that not every orthopedic surgeon sees both all age ranges, and so I think that's kind of unique.
Yeah.
What sort of things do you see in children that are different?
Well, we see mostly fractures, but the fractures in children heal quicker and they heal at different rates. So, and then we see growth plate injuries as well, the injuries to the portion of the bone where the bone grows. So obviously your bones are much longer when you're an adult, and they grow through what we call growth plates. And so that's one thing that is unique to children is watching the growth plates. And when a child has a fracture, one thing that's important is to make sure that the growth isn't disturbed following the fracture.
Where do you do your surgery?
I have staff privileges at St. John Hospital and William Beaumont Hospital in Grosse Pointe and Henry Ford Cottage, and I also go to a surgery center at St. John's on 12 Mile.
And what would you say are some of the most common surgical procedures that you do?
I do a lot of arthroscopy and fracture fixation, mostly.
And when doing the repair and planning the repair of that, I would imagine that radiology imaging is important in kind of putting things back together, and it's probably advanced over the years, and you're probably very much in tune with your radiology colleagues to figure that out. So what are some of the advancements that have come along with imaging that help you? Our
imaging has improved quite a bit. We have imaging in the OR, and we have what's called a C-arm, and it's an image intensifier, and it's great because it moves on an arm, and it's an arc, so we can place it around the table. The tables are radiolucent, so the imaging can be done right in the operating room, which is very nice, and we see the image immediately.
I wasn't aware of that. That's interesting.
Yes. Yeah,
And I imagine that's very, very helpful.
it is very helpful.
And do you know, if, say, for example, somebody has a fracture, you're probably immediately coordinating with them their physical therapy and their recovery, and you get the family engaged.
Right. Well, the first thing is get the fracture to heal, yeah, and to make sure they can, walk safely on crutches. So the therapists come in early to help with ambulation to make sure that they can use the crutches safely.
Some people probably want to do too much too soon.
We do have to try to get them to slow down at first after a fracture, absolutely, absolutely, because it does take time for fractures to heal.
And what is that time frame?
It depends. In the smaller bones, in the hands and feet, it typically is about 4 to 5 weeks. And in the larger bones, like the femur or thigh bone, those can take up to 3 months. Okay? So there is a large range, and it really does depend on which bone that you break.
And Dr. Henry Kelly, if a patient wanted to see you, is there a phone number that you could offer them, and where is the location of your office?
My office is in Warren on Shaner, just north of 696. So it's fairly easy to get to. And we do have a website. It's juliehenrymd.com. And the phone number is 586-754-4417.
Very, very good.
Yeah.
Well, it's been a pleasure having you as our guest.
Thank
A
you.
wealth of information, and it's so interesting to hear such a comprehensive approach to your specialty, and really appreciate that.
Thank you.
Thank you very much, Dr. Henry.
Thanks.
And thank you to our viewers as well. Thank you for tuning in. We appreciate that. Take good care of yourself and those around you, and we'll see you next time. Great, great.